Welcome to Board Pearls. This is episode 1 of 2 of the liver test interpretation chapter in the liver disease module. This episode is the pattern-driven workup, the R ratio that sorts hepatocellular from cholestatic injury, the hepatocellular workup through viral, autoimmune, metabolic, ischemic, and drug causes, and the cholestatic workup sorting intrahepatic from extrahepatic with ultrasound and MRCP as the anchors. Abnormal liver tests are not a diagnosis, they're a screening signal, and the whole workup is structured by which enzyme dominates and by how many multiples of normal it sits at. The framework that organizes the differential at the front door is the R ratio, which is ALT in multiples of the upper limit of normal, divided by alkaline phosphatase in multiples of the upper limit. The cutoffs are tight. R over 5 is hepatocellular injury, R under 2 is cholestatic, and 2 to 5 is mixed. The usefulness is that it sorts the patient into a workup track before any additional test is ordered, and since hepatocellular and cholestatic patterns share almost nothing in their differentials, the first move on any liver vignette is to compute R and commit to a track. Hepatocellular injury means hepatocytes are dying or leaking, and the differential is the acute hepatitis list, plus the chronic smoldering causes: acute viral hepatitis, drug injury, ischemic hepatitis, autoimmune hepatitis, and Wilson disease in younger patients acutely, plus fatty liver disease, alcohol, chronic viral hepatitis, autoimmune hepatitis, hemochromatosis, and alpha-1 antitrypsin deficiency chronically. The magnitude refines the differential, and the boards anchor the pattern to it. Acute viral or non-acetaminophen drug hepatitis typically produces an ALT in the hundreds to low thousands, while acetaminophen and ischemic hepatitis are the two that cross 5,000, with ischemia carrying a markedly elevated LDH and a hypotensive precedent in acetaminophen driving a rapid rise and fall over days. Autoimmune hepatitis runs in the mid-hundreds in the chronic phase. Chronic viral hepatitis and fatty liver sit lower, and alcohol-associated hepatitis runs modestly elevated with the AST capped under 400 and a characteristic AST-to-ALT ratio over 2. That AST-to-ALT ratio is its own discriminator and is tested directly. AST greater than ALT in otherwise typical chronic hepatitis suggests cirrhosis from any cause because as the liver fibroses, the ALT declines disproportionately given its shorter half-life, and AST to ALT over 2 with AST under 400 in a drinking patient is alcoholic hepatitis until proven otherwise. And transaminases in the thousands point to acute toxic, ischemic, or fulminant viral injury separated by tempo, history, and serology, rather than by the value alone, the very high ALT differential being acute viral, ischemic, drug, autoimmune, and Wilson. One more early decision is the value of normal itself. The old normal range for ALT was set on populations that unknowingly included fatty liver and undiagnosed hepatitis C, which inflated the upper limit, so the current practical normal is under 25 for women and under 33 for men, which means an ALT in the high 30s or 40s in a metabolically loaded patient is no longer normal and shouldn't be dismissed. So the front-end move is compute R, classify the magnitude of ALT, note the AST to ALT ratio, and you frame the answer before the stem is over. Now the hepatocellular workup, the track when R is over 5, layered and sequenced by pretest probability and reversibility, running viral, autoimmune, metabolic, ischemic, and drug, with each layer having a defined initial panel, and the boards favor ordering the high-yield first-line tests in one round, rather than chasing single tests. Viral is first because the diseases are treatable, transmissible, and ubiquitous. The initial panel is hepatitis B surface antigen and hepatitis C antibody with reflex to the RNA, hepatitis AIgM in an acute presentation, hepatitis EIgM in returning travelers or the immunocompromised, and EBV and CMV testing when the features suggest mononucleosis, the vignette being a young patient with fatigue, sore throat, splenomegaly, and a mildly elevated ALT. Herpes hepatitis is the rare but lethal differential in a pregnant or immunocompromised patient with very high ALT, mental status changes, and fever, diagnosed on biopsy inclusions or PCR, and empiric acyclovir started when suspicion is high because untreated HSV hepatitis carries a very high mortality. Autoimmune is second because the disease is treatable and the antibody panel turns around fast. ANA, anti-smooth muscle antibody, anti-LKM1, and a quantitative IgG, where type 1 presents with ANA and smooth muscle positivity, in a middle-aged woman with elevated IgG, and type 2 with anti-LKM1 more often in children. The simplified diagnostic score builds on antibody titers, the IgG level, compatible histology, and the absence of viral hepatitis, with a score of 6 probable and 7 or more definite, and the catch is that a meaningful minority of autoimmune hepatitis is seronegative, which is why biopsy is recommended in most suspected cases. So the textbook stem is the young woman with fatigue, an ALT in the high hundreds, high titer ANA and smooth muscle antibody, and an IgG well above normal. The metabolic and inherited layer is third because the diseases are common, the miss is consequential, and the screening labs cheap. Hemochromatosis is screened with fasting transferrin saturation and ferritin, and a transferrin saturation over 45% with elevated ferritin in a non-inflammatory state proceeds to HFE gene testing, with the trap being that ferritin is an acute phase reactant elevated in fatty liver, alcohol, and any inflammation. So ferritin alone without an elevated transferrin saturation doesn't warrant gene testing, since many fatty liver patients have a high ferritin and almost none have hemochromatosis. And anchoring on transferrin, Wilson disease is screened with ceruloplasmin in any patient under 55 with unexplained liver disease, with a low alkaline phosphatase and low uric acid supportive, whereas ceruloplasmin under 20 is suggestive, but not specific because it falls in malabsorption and synthetic failure, and over 30 effectively excludes it, with the diagnosis using the Leipzig scoring system that assigns points to Kaiser-Fleischer rings, low ceruloplasmin, neurologic symptoms, urine copper, hepatic copper over 250 micrograms. The Wilson vignette is a young patient with hepatocellular injury and new neurologic findings, Kaiser-Fleischer rings on slit lamp, a low ceruloplasmin, and a high urine copper, with a Coombs negative hemolytic anemia and acute liver failure, the classic clue to a Wilsonian crisis. Alpha-1 antitrypsin deficiency is screened by phenotype and genotype rather than the serum level, which varies as an acute phase reactant, with the detail in Chapter 22. And the metabolic layer includes steatotic liver disease, diagnosed by imaging steatosis, plus a cardiometabolic criterion with exclusion of significant alcohol and other causes, and non-invasive fibrosis assessment replacing routine biopsy, with the trap being that a notable share of fatty liver patients carry a low-titer autoimmune antibody or an isolated ferritin elevation that doesn't overturn the diagnosis. The ischemic layer is recognized by pattern, not an antibody. Shock liver presents with a rapid rise of transaminases into the thousands or tens of thousands, an LDH elevated out of proportion with an LDH-to-ALT ratio over 1.5, and a recognized hypotensive precedent like cardiac arrest, septic shock, or a GI bleed. The bilirubin is mildly elevated relative to the transaminases, an important discriminator from acute viral hepatitis, where bilirubin tracks with them, and the course is rapid, peaking within a day or two of the insult, and falling by half every day or two as perfusion is restored, with liver failure unusual unless the shock is unrecovered, and ischemia accounting for a large fraction of severe acute liver injury. The drug layer is last, but it's the diagnosis of exclusion, not of last resort, so the medication history has to be exhaustive across prescription, over-the-counter, herbal and dietary supplements, recreational drugs, and acetaminophen exposures, with supplements accounting for a significant share of drug injury. Anabolic steroids and green tea extracts the dominant offenders, and the R ratio at presentation classifying it as hepatocellular, mixed, or cholestatic. Hy's law is the prognostic anchor and is tested directly. An ALT over 3 times normal with a bilirubin over 2 in drug injury without obstruction carries about a 10% mortality, even with prompt drug discontinuation, and the classic offenders are amoxicillin, clavulanate, isoniazid, nitrofurantoin, trimethoprim sulfamethoxazole, minocycline, statins, and the herbals. When the standard panel is negative, the differential expands to hepatitis E in the immunocompromised, unusual infections, intermittent biliary obstruction producing a hepatocellular pattern, infiltrating tumors, and rarely hemophagocytic lymphohistiocytosis, and if the patient isn't improving with no clear etiology, biopsy is reasonable. So the hepatocellular workup is rewarded by its order. Viral first because treatable and transmissible, autoimmune second because the panel is fast and the disease responds to steroids, metabolic third because the labs are cheap and the miss is consequential, ischemic recognized by pattern, and drug last because it's exclusion. Now the cholestatic workup. The track when R is under 2, where the biliary epithelium and canalicular machinery are involved, and the workup branches at a single imaging finding, Is the biliary tree dilated or not? The first move is a right upper quadrant ultrasound, fast and cheap, answering whether there's extrahepatic dilation pointing to a mechanical lesion or an intact tree pointing to intrahepatic disease. If ultrasound shows dilation, the workup pivots to defining the level and cause of obstruction, with MRCP the non-invasive modality of choice because it images the whole tree without contrast or procedural risk. CT added when an extraductal mass like pancreatic cancer or hilar cholangiocarcinoma is suspected. Endoscopic ultrasound with aspiration the next step when a mass needs tissue, especially for distal obstruction, where pancreatic head cancer dominates, and ERCP reserved for when therapy is anticipated, stone extraction, stent, or the risk-stratified algorithm for bile duct stones lives in the biliary chapters, but the short version is that high probability goes directly to ERCP, intermediate to ultrasound, or MRCP, or intraoperative cholangiogram, and low to cholecystectomy with intraoperative cholangiogram. If ultrasound shows no dilation, the workup pivots to intrahepatic cholestatic disease with a short, reflex-driven differential. The first reflex is anti-mitochondrial antibody and a quantitative IgM for primary biliary cholangitis, where a positive antibody with an alkaline phosphatase over 1.5 times normal and AST under 5 times normal establishes it with a very high predictive value, allowing a no biopsy diagnosis in the vast majority. A small fraction is antibody negative and requires biopsy, with alternative antibodies accepted as serologic anchors when available, and the histologic signature being destruction of the small intralobular bile ducts with granuloma formation. The teaching trap is that a positive antibody in someone with normal liver tests rarely progresses to disease, so it isn't a screening test, ordered only when the cholestatic pattern is established and the diagnosis is on the differential. Primary sclerosing cholangitis is the second reflex when the pattern is intrahepatic and the antibody is negative, especially with inflammatory bowel disease, diagnosed by MRCP showing multifocal strictures of the intra- and extrahepatic ducts, with the classic beaded appearance, at lower cost and risk than ERCP, with biopsy not required when the cholangiogram supports it. Biopsy in this disease is reserved for two situations: small duct disease with a normal cholangiogram and the characteristic onion skin paraductal fibrosis on biopsy, and suspected overlap with autoimmune hepatitis, defined by an ALT at least 5 times normal without biliary obstruction. It's strongly associated with inflammatory bowel disease, typically ulcerative colitis, and the alkaline phosphatase is often normal at any single check and fluctuates, which is exactly why MRCP, rather than the lab pattern, drives the diagnosis. IgG4-related sclerosing cholangitis is the third reflex when the cholangiogram looks like sclerosing cholangitis, but the patient doesn't fit the phenotype, being the biliary manifestation of IgG4-related disease, often with pancreatic and other organ involvement, where a serum IgG4 over 135 is suggestive but not specific. The strictures tend to involve the intrapancreatic and proximal ducts, and they respond to corticosteroids, which is the diagnostic and therapeutic discriminator. So the favored vignette is an older man with painless jaundice, a distal biliary stricture, and pancreatic head fullness, who looks like pancreatic cancer until IgG4 is checked and steroids reverse the picture, and recognizing this prevents an unnecessary Whipple. The remaining cholestatic differential includes drug-induced cholestasis from amoxicillin clavulinate, anabolic steroids, and oral contraceptives, parenteral nutrition cholestasis, infiltrative disease like sarcoidosis, amyloid and lymphoma, genetic and congenital causes, and sepsis-driven cholestasis in the critically ill without obstruction, with biopsy the path forward when persistent unexplained cholestasis remains. So the cholestatic workup is also rewarded by order: ultrasound first to split mechanical from intrahepatic, MRCP for the biliary tree, endoscopic ultrasound for the mass, and ERCP only for therapy, then the antibody and IgM for primary biliary cholangitis, with the alkaline phosphatase and AST thresholds allowing a no biopsy diagnosis. MRCP for sclerosing cholangitis when the picture fits, with biopsy held for small duct disease and overlap, IgG4 for the steroid-responsive mimic, and biopsy when persistent unexplained. The mixed pattern, R between 2 and 5, sits between the tracks and is most common in drug injury, EBV and CMV hepatitis, and sclerosing cholangitis with active inflammation, and it doesn't have its own coherent differential, so it's worked up by addressing both directions in parallel. So the synthesis is the same logic repeated. Compute R first, commit to a track. Within hepatocellular, Run the 5 layers in order. Within cholestatic, image the biliary tree first, then run the intrahepatic serologies in order. The candidate who memorizes the panels but skips the ordering wastes tests and misses the answer. Episode 2 picks up where the pattern-driven workup breaks down the isolated bilirubin elevation, conjugated versus unconjugated with everything else normal, the isolated alkaline phosphatase that may be liver or bone, sorted by GGT before any cholestatic workup begins, the imaging and non-invasive fibrosis tools that come after the labs, with the elastography and blood panel cutoffs anchored to etiology, and the liver biopsy indications where tissue still changes management, with the percutaneous versus transjugular decision turning on ascites, coagulation. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 1 of 2 of chapter 17, and I'll see you in the next one.